Welcome to the deep dive. Today we're plunging into something really central to, well, keeping us alive. How your body manages blood pressure and, along with it, cardiac output.
That's right.
Anyone who's, been near a clinic knows vital signs are key and blood pressure, it's right up there. It's absolutely fundamental for getting blood and oxygen out to all your tissues, what we call organ perfusion.
Mm-hmm.
If that pressure tanks, that's shock, which is obviously dangerous, but too high, that's hypertension, and, well, that's just as critical in the long run.
Absolutely. And our mission today, really digging into the medical physiology text, is to sort of unravel the body's mechanisms, both the super fast short-term ones and the slower long-term strategies for regulating arterial pressure and cardiac output. We'll look at how the heart and blood vessels coordinate.
Okay, so let's start with this great analogy from the book. Instead of just a pump pushing water around, think of the circulatory system like a city's water tower.
Yeah.
It provides this constant pressure, a steady supply to all the houses. And the key thing is, each house can draw the water it needs, just like each organ controls its own blood flow.
Right. Local control.
Exactly. And if one house uses a ton of water, it doesn't make the pressure drop next door because the system's main job is keeping that tower pressure stable. That's what we want to explore today, make these complex ideas feel relatable and clear.
Okay, so let's tackle the body's rapid response first, the short-term stuff. This happens over seconds to minutes, mainly using neural reflexes. Think of it like a thermostat for your blood pressure, constantly making adjustments.
A negative feedback loop.
Precisely. And any loop like this has 5 basic parts. You need a sensor, a detector to measure the blood pressure. Then efferent pathways, basically nerves, to send that signal to the brain.
Okay.
Third, a coordinating center in the brain compares that signal to where it should be, the set point. Fourth, efferent pathways, more nerves, carry commands from the brain. And finally, the effectors, the organs, like the heart and blood vessels that actually make the change.
Got it. So the detectors, the main sensors for blood pressure are the baroreceptors.
Yes.
And the fascinating thing you mentioned is they're not actually pressure gauges, they're stretch receptors, mechanoreceptors.
Right.
They feel the vessel wall physically stretching.
Exactly. They're strategically placed in high-pressure zones. The carotid sinus, which is this expandable bit of the carotid artery up in your neck.
Right near the branching point.
Yeah, and the aortic arch, a really compliant part of the aorta close to the heart. And it really is about stretch. If you, say, put a rigid cuff around a vessel so it couldn't expand, the baroreceptors wouldn't fire more, even if pressure inside went way up. No stretch, no signal increase.
Wow, okay. That makes sense. It's the physical deformation.
Precisely. And they're very sensitive. When pressure rises and stretches the wall, that physical change generates an electrical signal. It's graded more stretch, bigger initial signal, than a steady signal.
And that electrical signal gets translated.
It gets translated into the frequency of action potentials, electrical impulses going up the nerve. So higher pressure means more stretch, which means a higher frequency of signals to the brain. It's like frequency modulation.
So it encodes the amount of stretch.
And how fast it's changing, too. They pick up on the pulse waveform, those bursts of signals you see with each heartbeat carry info about pulse pressure, the difference between systolic and diastolic. They have a range firing very little, around 40, 60 millimeters of mercury and maxing out around 200. Different nerve fibers kick in at different pressures, so you get this graded response.
That's incredible detail. And you mentioned differences between the carotid and aortic ones.
Yeah, subtle but important. The aortic arch receptors need higher pressure to even start firing, around 110 millimeter Hg compared to maybe 50 for the carotid. They're also a bit less sensitive to how fast pressure changes, and they don't react quite as strongly if pressure drops.
And that has clinical relevance.
It can. Some people have a hypersensitive carotid sinus. Just turning their head sharply or wearing a tight collar can compress or stretch that sinus, triggering the reflex strongly, dropping their blood pressure, and they might even faint. It's an overreaction, essentially.
Okay, so the signal goes from these receptors up the nerves, the efferent pathways. Where do they go?
So from the carotid sinus, it's the sinus nerve, part of cranial nerve 9. From the aortic arch, it's fibers in the vagus nerve, cranial nerve 10. Both pathways lead to the same place in the brainstem. The nucleus tractus solitari, the NTS.
The NTS, that's the main coordinating center you mentioned.
That's the one. The major hub processing all this incoming pressure data. It then sends out instructions. If pressure's high, for example, it sends inhibitory signals to the part of the medulla that normally causes vasoconstriction.
Tell it to ease off.
Exactly. And it sends excitatory signals to the areas that slow the heart down.
And those instructions go out via the efferent pathways, the autonomic nervous system, sympathetic and parasympathetic.
Correct. So high baroreceptor activity, meaning high pressure, causes the NTS to inhibit sympathetic outflow. It dials down the signals telling your heart to speed up and your vessels to constrict.
Resulting in vasodilation and slower heart rate.
Right. Vessels relax, heart slows down, pressure drops. That's why a high spinal cord injury above T1 can cause such a steep drop in blood pressure, you lose that sympathetic drive from the brain.
And the parasympathetic side.
Increased baroreceptor firing stimulates the parasympathetic system, specifically the cardioinhibitory area. Signals go down the vagus nerve mainly to the heart, slowing it down.
Okay, so let's talk about the effectors, the organs doing the work. The heart first.
Okay, the heart. Sympathetic nerves release norepinephrine, hitting beta-1 receptors. This boosts heart rate and contractility, how forcefully it beats. Interestingly, the right-sided nerves tend to affect rate more. The left side affects contractility more.
And parasympathetic.
That's the vagus nerve releasing acetylcholine onto M2 receptors. This primarily slows the heart rate, especially acting on the SA node, the pacemaker. It also slows conduction through the AV node a bit and slightly reduces contractility, but the main effect is on rate.
Makes sense. What about blood vessels?
Blood vessels are mostly controlled by sympathetic vasoconstrictor fibers. They release norepinephrine onto alpha-1 receptors, causing constriction. These are everywhere, but especially dense in places like the kidneys and skin, allowing blood to be shunted away if needed.
Is there parasympathetic control of vessels?
Much less widespread. Parasympathetic vasodilator fibers are mainly in specific spots. Salivary glands, GI glands, erectile tissue. They release acetylcholine, sometimes nitric oxide or VIP, but skeletal muscle has a unique sympathetic vasodilator system, releasing acetylcholine, important for the fight-or-flight response, getting blood to muscles.
Huh, interesting exception. And the adrenal medulla.
Ah, yes, the adrenal medulla. Think of it as a modified sympathetic ganglion. When stimulated by sympathetic nerves, it dumps epinephrine and a bit of norepinephrine straight into the bloodstream.
So it acts like a hormone.
Exactly, giving a global, system-wide sympathetic boost to circulation.
Wow. That whole neural reflex is incredibly complex but works so fast, it's the body's immediate guardian for pressure.
It really is, constantly fine-tuning.
Okay, but like you said, pressure is one thing, but we need to deliver volume. That brings us to cardiac output. All right, so we've got the rapid pressure controlled down.
Yeah.
Let's shift to cardiac output, CO. That's the total blood volume pumped per minute, right? Heart rate times stroke volume.
Correct. Heart rate, HR, times the volume pumped per beat, stroke volume, SV. And the heart controls these both intrinsically from within and extrinsically through nerves and hormones.
So intrinsically, how does the heart manage itself?
Well, heart rate is fundamentally set by the SA node's own electrical rhythm. Factors like its resting potential, how quickly it depolarizes on its own, and the threshold to fire and action potential all play in.
Okay, and stroke volume.
Stroke volume is simply the difference between the volume in the ventricle before it contracts, that's the end diastolic volume, or EDV.
How full it gets.
Right, and the volume left after it contracts, the end systolic volume, ESV, how much it ejects.
So what determines EDV and ESV?
Good question. EDV, the filling volume, depends on the filling pressure coming back from the veins, how much time the ventricle has to fill between beats, less time at higher heart rates, and how stretchy or compliant the ventricle wall is.
And ESV, what's left behind?
ESV depends on a few things. Preload, which is basically the EDV itself. The more blood stretches the muscle, the stronger it contracts. That's Starling's law. Then there's afterload, the resistance the heart pumps against in the arteries. Also, heart rate itself, higher rates, can increase calcium inside the cells, boosting contractility. And finally, the baseline contractility or strength of the heart muscle, which can be altered by drugs or hormones.
Okay, so alongside the high-pressure baroreceptors, you mentioned another set of sensors?
Yeah.
The low-pressure baroreceptors.
Yes, these are different. They're located in the low-pressure parts of the circulation, the pulmonary artery, where the big veins join the atria, and within the walls of the atria, and even the ventricles.
And their job?
They're essentially monitoring the fullness of the system. How much effective circulating volume there is, basically. Is there enough blood available to properly perfuse everything? They're like volume detectors.
Got it. And the atrial ones are key.
The atrial receptors are the best understood. They have two types of nerve endings. Fibers fire with atrial contraction, so they mainly monitor heart rate. But the B fibers are really interesting. They fire during ventricular contraction when the atria are filling, and their firing rate increases as the atria stretch more. They peak with the V wave of the atrial pressure pulse.
So they're monitoring atrial volume. Central venous pressure.
Exactly. They're sensing venous return and giving the brain feedback on the effective circulating volume.
And these are linked to the Bainbridge reflex.
That's right. And here's the twist. Unlike the high-pressure baroreceptors that slow the heart when stretched, increased stretch of these atrial B-type receptors actually increases heart rate.
So more volume returning makes the heart beat faster.
Especially if the baseline heart rate is already a bit low, yes. It's like the heart anticipating the increased load and speeding up to handle it.
Fascinating contrast.
So putting it together, if your atria stretch more because blood volume is up, you get this three-part response. 1, tachycardia, faster heart rate via Bainbridge.
Okay.
2, renal vasodilation. Sympathetic signals specifically to the kidneys decrease, boosting blood flow there.
Interesting target.
And 3, diuresis. You produce more urine. This happens because the atrial stretch triggers less release of arginine vasopressin, AVP, or antidiuretic hormone.
So you retain less water.
Right. And also, the stretched atrial muscle cells themselves release atrial natriuretic peptide, ANP. ANP is a potent vasodilator, plus it makes you excrete sodium, natriuresis, and water, diuresis, all aimed at reducing that excess fluid volume.
Wow. So how do these reflexes, Bainbridge and the high-pressure baroreflex, interact when volume changes? The book called it peculiar biphasic dependence.
Yeah, it sounds complicated, but it makes sense. At low blood volumes, the high-pressure baroreceptor reflex tends to dominate. It increases heart rate trying to maintain pressure, and it also makes the heart more sensitive to filling, steepens the Starling curve for stroke volume.
Okay.
But at high blood volumes, the Bainbridge reflex tends to take over for heart rate control, pushing it up. And simultaneously, the high-pressure baroreceptor reflex is activated by the higher pressure, reducing overall sympathetic tone, which actually flattens the Starling curve for stroke volume a bit.
So heart rate and stroke volume respond differently depending on whether volume is low or high. That does sound complex.
It does, but here's the elegant result. Even though heart rate and stroke volume have these complex biphasic responses individually, when you multiply them together to get cardiac output, the result is remarkably smooth. Cardiac output rises monotonically steadily upwards as effective circulating volume increases.
So the competing effects balance out for the overall output.
Exactly. The Bainbridge reflex, the baroreceptor reflex, and Starling's law all work together, integrating beautifully to ensure output matches volume appropriately.
All right, we've covered the fast reflexes and how the heart adjusts output beat by beat. Now let's zoom out. How does the whole system ensure supply meets demand in the long run? You mentioned venous return has to match cardiac output.
In a steady state, absolutely. In a closed loop, what goes out must come back. This is where the concepts of the vascular function curve and the cardiac function curve really help visualize things.
Okay, let's start with the vascular side. What's mean systemic filling pressure, MSFP?
Imagine, hypothetically, you could stop all blood flow instantly. The pressure would equalize everywhere in the circulation after a few seconds. That uniform pressure, usually around 7 mm Hg, is the MSFP. It reflects the total blood volume filling the container of your vascular system, considering its overall stretchiness or compliance.
Okay, 7 mm Hg. And the vascular function curve, how do we picture that?
Okay, picture a graph. Horizontal axis is right atrial pressure, RAP, the pressure in the chamber receiving blood back from the body. Vertical axis is venous. Return the rate of blood flow back to the heart. As RAP falls, gets lower, even negative, the pressure gradient pushing blood back to the heart increases, so venous return goes up.
Makes sense. Bigger pressure difference drives more flow.
But there's a limit. When RAP gets too low, around -1 mm Hg or so, the big veins near the heart actually start to collapse under the surrounding pressure.
Oh, right.
This limits further increases in venous return, so the curve flattens out, it hits a plateau. The slope of the initial part of the curve depends on things like venous resistance and compliance.
So what makes that whole curve shift?
Two main things. First, blood volume. Add volume, like with the transfusion, and the whole curve shifts right. Your MSFP increases. Lose volume, like in hemorrhage, the curve shifts left, MSFP decreases.
Okay, volume is intuitive. What else?
Arteriolar tone. Those small resistance vessels. Now, they don't hold much volume, so changing their constriction doesn't change MSFP much. But if arterioles constrict strongly, it increases the overall resistance between the high-pressure arteries and the low-pressure veins. This makes it harder for blood to get back to the heart, so it flattens the slope of the vascular function curve. Less venous return for any given RAP.
Then dilation does the opposite.
Right. Arteriolar dilation decreases resistance, steepens the curve, allowing more venous return for a given RAP.
Okay, so that's the vascular side. What about the cardiac function curve?
That one's basically Starling's law plotted differently. It shows cardiac output on the vertical axis against right atrial pressure on the horizontal axis. As REP, which reflects preload, increases, cardiac output increases
Yeah.
up to a point.
So you plot both curves, vascular function and cardiac function, on the same graph.
Exactly. And in a stable system, venous return must equal cardiac output. This can only happen at the single point where the two curves intersect.
The operating point of the system.
Precisely. If, say, RAP momentarily went above that intersection point, cardiac output would increase, Starling, but venous return would simultaneously decrease, vascular function curve. This imbalance pushes the system right back towards that stable intersection point. It's self-correcting.
So if you want to permanently change cardiac output, you need to shift one or both curves.
You absolutely have to. For example, giving a blood transfusion shifts the vascular function curve, right? The intersection point moves, resulting in a new steady state with higher cardiac output and a slightly higher RAP.
And what if you boost heart contractility, say, with a drug?
That shifts the cardiac function curve up and to the left. The heart pumps more for any given RIP. The new intersection point will be at a higher cardiac output, but this time at a lower RAP, because the more efficient heart doesn't need as much filling pressure.
That intersection point really brings it all together.
It does. It's where all those short-term neural reflexes ultimately find their balance point over time. Okay, so moving beyond the immediate neural control and the mechanics of the curves, we get into intermediate and long-term control. This operates over hours, days, even longer, and relies heavily on humoral controls, chemical messengers in the blood.
Hormones and other substances.
Exactly. There's a whole range. You have biogenic amines like epinephrine from the adrenal medulla, we mentioned that. It constricts some vessels, alpha-1 receptors, but can dilate others, like in skeletal muscle, beta-2 receptors. Serotonin causes local vasoconstriction, important in clotting. Histamine is a vasodilator, key in inflammation.
Then there are peptides.
Lots of important peptides. Angiotensin II, ANG2, is a major one. It's a really potent vasoconstrictor central to the renin-angiotensin-aldosterone system, or RAAS. Normally, plasma levels aren't high enough for systemic effects, but during hemorrhage or when kidney blood flow drops...
That's when it kicks in.
Right. Low kidney perfusion triggers renin release, which leads to ANG2 formation. ANG2 then clamps down hard on blood vessels, especially in the gut and kidneys. This can actually become a dangerous positive feedback if kidney flow stays low. The classic Goldblatt hypertension model, where you constrict the renal artery, shows this perfectly at critically blood pressure via RAAS.
What other peptides?
Arginine vasopressin,
Yeah.
AVP, or ADH. At high levels, like in shock, it's also a vasoconstrictor. Endothelins are maybe the most powerful vasoconstrictors known, though their day-to-day role is still debated. On the flip side, atrial natriuretic peptide, ANP, from the stretched atria, is a vasodilator and promotes salt and water loss. And kinins, like bradykinin, are also vasodilators.
And non-peptides, gases.
Yes. Nitric oxide, NO, is a crucial local paracrine vasodilator produced by endothelial cells. But certain prostaglandins, like PGI2 and PGE2, also cause vasodilation. It's a complex soup of chemical signals fine-tuning vessel tone.
So many signals, but for the really long term, decades.
Yeah.
It comes down to the kidney, doesn't it?
Absolutely. The ultimate long-term regulator is the kidney. The body isn't just controlling anatomical blood volume, but this functional concept of effective circulating volume, basically, how well tissues are being perfused. And the kidney controls this by regulating the body's total sodium content. Sodium determines extracellular fluid volume, which directly influences blood volume.
So sodium is king for long-term volume and pressure.
It really is. Sensors detect changes in that effective circulating volume and signal the kidney via 4 main parallel pathways to adjust sodium excretion.
What are the pathways?
Number 1, and probably most important, is the RAAS, renin-angiotensin-aldosterone. 2, the autonomic nervous system directly influences kidney function. 3, AVP release affects water retention, which is linked to sodium. And 4, ANP promotes sodium excretion.
All converging on the kidney.
All telling the kidney to either hold on to sodium and water, raising volume and pressure, or get rid of it, lowering volume and pressure. That's why chronic kidney disease is so often linked to hypertension. And it helps explain the difference between primary hypertension, where we don't know the exact cause, and secondary hypertension, like renal artery stenosis, where fixing the kidney issue can sometimes cure the high blood pressure.
It all comes back to the kidney in the end for that long-term stability. What a journey.
It really is, from split-second reflexes to hormonal cascades to the kidney's slow, steady control.
So just to recap, we've gone from those immediate neural reflexes, the baroreceptors constantly monitoring stretch, sending signals through the NTS to adjust sympathetic and parasympathetic output to the heart and vessels.
To the intrinsic properties of the heart and how cardiac output relates to venous return via those function curves.
And finally, the layers of humoral control, NG2, ADP, ANP, and the kidney's ultimate mastery over sodium and water balance for long-term pressure regulation.
It truly highlights how interconnected everything is. A disturbance in one part can ripple through the whole system. Understanding these connections is key to grasping both normal function and disease states like hypertension.
Physiology can definitely feel overwhelming sometimes, but you've just walked through some incredibly core concepts. You've seen how the body works nonstop to maintain this crucial balance. Remember, even the most complex system is built from understandable parts working together. You absolutely can master this. Keep making those connections. You're part of the Deep Dive family, and you've definitely got this.
And maybe something to ponder. Considering all these feedback loops, what happens if just one component, say a specific receptor type, becomes less sensitive over time or maybe overactive? How could that one small change cascade through the system and potentially contribute to a chronic condition like hypertension? And what does that tell us about how we might target treatments?